Welcome everybody to the Mayo Clinic. My name is Dr. Frederick Meyer. I'm the Eline Professor and Enterprise Chair of Neurological Surgery at Mayo Clinic. I'm also the Executive Dean of the Mayo Clinic College of Medicine and Science, and I'm the Dean of the Mayo Clinic Alk School of Medicine. Also happen to be the Executive Director of the American Board of Neurological Surgery. Today we're operating on a 27-year-old woman. She's right-handed. She presents with a long history of intractable seizures, medically refractory seizures. For years, she's been on a compilation of medications, multi-therapy without benefit. An MRI scan, as you will see, demonstrates a cavernoma in the right non-dominant temporal lobe. Hence, this is a very straightforward case. Essentially, a lesionectomy, meaning resection of the cavernoma, resection of the hemosiderin-stained brain, to try to get her a great outcome from an epilepsy control perspective. Our goal today is to give her an Engel Class 1 seizure outcome, meaning medically free of seizures. Let's go to the operating room and I'll show you the films and talk about what we're going to do. I also want to mention a few facts about if this was in the dominant left temporal lobe, how we might approach it differently. But today's case is eloquent in its simplicity. Thank you for joining us. Appreciate it. This is a 40-year-old right-handed woman who's suffering from medically intractable seizures. She's been on multiple medications over the years, up to a triad of 3 without benefit. And as we can see, quite obviously, there's a cavernoma. Her prolonged video EEG recordings confirm that her seizures are coming from this region. So most of the time when there's a lesion, it's the source of the seizures. And so the goal of surgery today will be to take out the cavernoma and the hemosiderin-stained brain around it. So this imaging demonstrates the cavernoma quite nicely. You can see it over here also. And I'll point down this T2. We can see that there's sort of a sulcus. So the plan here, it's a very straightforward type of surgery, but nonetheless, every surgery is important. It should be done well. The neurological risk here is minimal, other than potentially capturing or injuring some of the optic radiations in here, so one has to be careful going deep when you're resecting the hemosiderin-stained brain. So the goal here will be to do a stereotactic craniotomy. The stereotaxis is to localize, lessen the incision in the craniotomy. We'll probably make a linear incision, with this being the epicenter here, targeting that sulcus. So oftentimes I'll do an intrasulcus approach to the cavernoma, to the tumor, to the lesion to minimize injury, take out this cavernoma, take out the hemosiderin-stained brain, and then stop. I would comment that not uncommonly, we'll do some intraoperative electrocorticography. Once in a while, you can find a seizure focus a little distant from the actual structural abnormality, but in this case, we have decided just to go straight ahead with the lesionectomy. Now, an interesting question arises if we look over here. If, let's say, this cavernoma was on the left, so dominant language risk, I would have done a functional MRI scan to try to localize where language is, number one. Number two, if language was really quite intimate with the cavernoma and a decision was made to do surgery, we'd have 2 options. One option would be to do the surgery awake, which of course is an option. The second choice would be just to assume, which you always do, that everything around that cavernoma, if this is on the left, is eloquent, and therefore one would be very cautious just to take out the cavernoma and not violate the surrounding brain. So 2 ways to approach it if it was on the dominant side and you're worried about language injury, depending on the location of a functional MRI definition of where traditional angular gyrus where these areas located. In this case, since it's the right, we don't have to worry about any of that. And as I said, this should be a very straightforward, simple surgery. So we've chosen a surgical position with this patient, supine. You'll note that there's a bump under the shoulder and a slightly reversed Trendelenburg position. At least for me, in any type of craniotomy, especially with a tumor or any lesion, I always prefer that the head is higher than the heart. I don't like neurosurgery in a flat position. I think it's healthy for the brain to have a slight reverse Trendelenburg to facilitate a venous return. So here we're going to put on a pinion. Why? Because we want to fix the head, simply because we're going to use stereotaxis for localization. we can presume that the incision is going to be linear, probably right about here. And again, for me, if the left side is dominant, I tend to put 2 pinions on the left side. Just I don't want to be that unlucky to cause a skull fracture. And when you have 2 pins, it dissipates the pressure better. So I try to put the left, 2 pins on the left in the hairline so there's no cosmetic problems. And this should work pretty well. And of course, as we all know, you do a closing pressure of about, what, 70 torr, and that's about it. And then, of course, thank you, you want to do a little shake chest to make sure it seems solid. And now we're going to think about position. For me, I always like the ear and the eye on the same plane. It just helps me with my own sense of orientation. So even though this is a pretty straightforward operation, you know, it can be a very eloquent and very satisfying surgery. So in her case, since she has a lesion and she has intractable epilepsy, if we do a nice job of taking out the cavernoma and hemosiderin stained brain, she has about an 80% chance of having a angle class 1 seizure outcome, meaning seizure free with a good chance of being off anticonvulsants over time. Of course, for her and most patients with intractable epilepsy, one of their main goals is to drive. And that independence of driving, something we take for granted, is something that an individual like this desperately wants. Okay, so let's register the stealth. So we're applying a classic stereotactic system. It really doesn't matter what type of stereotactic system you use, they all work well. Just as a caveat, I like to have this as high as possible to prevent blockage of line of sight to make surgery quicker. Of course, some think that the closer this is to the target, the more accurate. I'm not sure that's exactly true or not, but nonetheless, this is a pretty good position. So here we're doing the classic registration, point registration, and we'll look at our accuracy. If we're unhappy with the accuracy, we'll repeat certain markers that seem inaccurate or even consider face tracing. So you can see a lot of facial tracing. We'll see if that improves our accuracy. So in this particular patient with the facial tracings, our accuracy is down to 1.1, which is actually about as good as it gets. So I think we'll stop and proceed. So with a cavernoma, as we know, a gradient echo is a beautiful way to show us the lesion. So that looks like we're near the epicenter, right about here. So the lesion's sitting right in here. In my neurosurgical practice, I avoid haircuts. There's no evidence that cutting hair decreases infection. So, and as I said before, I think cosmetics are hugely important, and because that's the only thing a patient really sees. So we know that the cavernoma is here. If we want to think about anatomy for a second, the transverse sinus is here, right? Going into the sigmoid sinus here. There may be a vein of Lobe that we'll want to be cautious about. If this was on the left side, we'd be particularly cautious about the vein of Lobe. But on the right side, nonetheless, we'll want to be cautious. When we look at the preoperative imaging, I don't see an obvious venous angioma, but oftentimes cavernomas are associated with the venous angioma, so we'll want to be mindful for that. So it seems to me a nice incision here would be just really quite a straight incision, just like that, down to the transverse sinus, like that. And then we'll do a circular craniotomy around that. And as I said, we can really give her a lovely cosmetic result by just making a linear incision by dividing her hair. We'll give just the slightest of haircuts, just because it's easier to sew the skin back together. And if you do that, then the stitches won't get caught in the hair, or the staples won't get caught in the hair, and then when they get taken out, it causes less patient discomfort. I like to use, most of the time, staples for surgery. I let the patients shower and wash their hair the day after the operation. In this type of relatively small incision, we may not use a drain. Otherwise, I almost always use a drain in craniotomies. since it's valuable in facilitating wound healing. So now we're going to prep and drape and get this operation going. So we're ready to start the surgery. The scalp's been injected with a 0.5% bupivacaine.
Yes, sir. We have a fine tip to maximize.
All right, we're going to start the incision, as you can all see.
Incision.
We're using a fine tip Bovie cautery. I must confess that I like the bipolar even for the skin. You have to be careful when using the Bovie cautery that you don't burn the skin and lead to wound healing problems later on. Of course, since we're using a small incision here, we want to make sure that we maximize it by giving us the largest craniotomy. It's important to have a good craniotomy because we want to try to identify a sulcus to work through. So I would comment that if we're not happy with the size of the potential craniotomy, we may want to extend the incision both up and down just a little more, perhaps. It's important to recall that linear incisions heal really quite well, and you want to be able to have enough of an incision to really give yourself a reasonable craniotomy to do a good and safe operation. So before we conclude the sharp craniotomy, we'll pull the stereotaxis in just to make sure that we really have access that we want. So we're going to make a single burr hole with the B1 bit here. Why don't you make that, it's going to be low, so cosmetically it will be covered by the temporalis muscle, so the patient's not going to feel much of a bony defect. So my colleague is going to maximize this incision by carving the largest craniotomy that's physically possible. So the craniotomy, the burr hole doesn't need to be that large, but it should be large enough to be able to fit the foot plate underneath to make your life easier. When you drill, you want to irrigate to prevent scorching of the brain. So we're going to use a curette to peel off any shelf of bone. Looks like a nice burr hole. We can see the dura. There's no significant bleeding, and so the next step will be to take a Penfield 1 and then a 3 to peel the dura off the underside of the bone. Now we're making the craniotomy as large as possible. Sometimes you get stuck with the plate on the underside of the bone because of a bony ridge, and you can just sort of wiggle it a little. If that doesn't work, you can come from the burr hole from the other side and connect it to cuts. So we're completing the cut, and of course common sense would tell us to not pull up when we finish the cuts to avoid popping the bone. So our surgical system has this thing around the bone just to be safe, of course. There we go. We can see the dura has been nicely exposed. The next step will be drilling 3 to 4 tack holes and tacking the dura and then opening it. So the truth of the matter is it's hard to close the dura primarily in any type of craniotomy and make it watertight. But in this sort of case, we'll open the dura in a crisscross fashion to give us good exposure, and normally I'll close the dura maybe with a little piece of muscle as an online graft to make sure, if possible, that it's watertight. I prefer to use a patient's own material, own tissue, as opposed to a synthetic material. I usually do not use fibrin glue. Now, if there's not a good way to drill a small tack hole, you can put the stitch in the buckle. And obviously, you don't want to drill a hole too low here and accidentally put a hole in the mastoid stitch. So after this, we're going to open up the dura. We're going to bring the operative microscope into play, and I'll go scrub and assist my colleague.
Can we bring the microscope in?
We have a patty over here. Just sometimes, when you open the dura, the brain can get herniated against the edge of the dura and get contused. So we have a patty there to prevent that from happening. And now we're just going to use the stealth system. And we're just going to look for a moment and try to see what's a good trajectory. I can see there's a sulcus here. Maybe we'll open that up. There's an artery there I'd like to preserve. Or it may just be, depending on the anatomy, we may end up just wanting to make a small cortical incision in there and access the cavernoma. This looks to be a vein of Lobe, so obviously we want to preserve that. So we're just going to look around for a moment, and basically what I'm doing here is using the stealth or the stereotactic guidance system, trying to see a good access point. Chris, where do you think the epicenter is? Right there.
Yeah.
So the epicenter of the cavernoma is here, quite honestly. Should we go through this sulcus? It's not a great sulcus. Should we open that there and then just sort of extend it that way? We'll take a look and see how it lays out here for us. So, we have an artery here. There's a vein there. A good point might be right in here, huh? It's not a great sulcus. Little contusion right here. We could go through there. Let's see what the stealth looks like a little here. So I think we'll try starting right in there. So grab a ruler for a second. So that would be a cortical of about 4 millimeters or so, 4 or 5 millimeters. Because again, there's not a great sulcus. There's a sulcus in here, but that runs the risk of injuring that artery, and it doesn't look like it's going to give me great aperture. There's a sulcus here with a spanning vein. We'll probably end up taking that and coming like this. So we'll just sort of gently go into here and see what we find. And expand our incision as needed. So we're going to gently, please, expand our incision, and what we're really looking for now is some hemosiderin stained brain. That will be the tail mark. So we can see right there some hemosiderin right there.
Yes, sir.
Do you agree?
Yes, sir.
So, again, this is a non-eloquent brain. All this hemosiderin stained brain can cause epilepsy. What we're really looking for is the nidus, the true cavernoma, but I think we can see quite nicely. We can see there's the cavernoma peeking through right there, right?
Yes, sir.
Now, cavernomas oftentimes have small little blood vessels around it, going to it. Not high flow vessels, but small little capillary type of level vessels. So, again, in addition to taking out the cavernoma, there's a branch of the middle cerebral artery right there. See it?
Yes, sir.
But we do want to take out, so the cavernoma's here, the hemosiderin's here, and I think it's advantageous from an epilepsy perspective to take out as much of the hemosiderin stained brain as you feel comfortable doing. So we want to take out all the feeding arteries going to this, the hemosiderin stained brain, but not normal brain, normal blood vessels. So in this quadrant, we've probably accomplished that. Again, we're also going to be mindful of the possibility of there being a venous angioma, which at this point I don't see, but we have to be mindful of it. So cavernomas are not technically difficult lesions to take out in most locations. Usually the issue is one of how you access it. So here, this was straightforward access, but let's say a pontine cavernoma is obviously going to be more dangerous. Not dissimilar to taking out a small net. So that's about half of it that we've taken out. You can see the middle cerebral artery is just above my bipolar. We're going to protect that, of course. And now we're going to reposition the scope and have my resident take out a little of this. So we have a nice plane going on there. Cavernoma's in there. Once we take this out, we'll come back and we'll look, and we will again make sure we've removed all the hemostenotic stained brain on. As my resident's going to resect some of this, I could, if I wish, do just a touch of retraction like that to make it easier for him to see. And the plane will be right in there. You can see we're almost, black patch, we're almost at a sulcus interface or a peel boundary, which I will expect that he will respect. You see that? So there's the middle cerebral artery there. We're going to want to protect that. So there's a small artery going right to the cavernoma there. I'll get that and then you can take over. Bipolar. So I'm going to put a pen field in to help my colleague
Can you raise the table a little bit?
see the cavernoma just a little better. We can see my pen field at this point in time is right
Great,
at the
thanks.
interface between hemosiderin stained brain and normal brain. So I would start there. Yeah. One of the problems with operative microscopes, of course, is that they don't have stereoscopic views through the sidearms. So in this type of situation, if you're trying to assist a colleague, resting your hand on the head is a very nice way to stabilize, prevent yourself from slipping or doing some sort of harm. So there's a great example of a little vessel going to the cavernoma. After we cauterize it, we will cut it. To save time in an operation, I tend to cauterize multiple blood vessels, then hand off my bipolar, get a micro scissors, and cut all those blood vessels at once as opposed to doing them individually back and forth. Just saves time. So now you're getting into the heart of the cavernoma on the deep side, right?
For sure.
And so again, we want to make sure that there's no venous angioma. Patties, of course, are helpful because they increase the surface area of your suction tip. Venous bleeding is usually never, or most often is not a problem. Tamponade, even in major situations, can take care of bleeding as opposed to an arterial bleed.
For sure.
There you go. Now you can really see the cavernoma. It has that mulberry appearance to it. Good. So the cavernoma is out, and now I'm going to switch places with my resident and just take a look at the hemosiderin part of it. So we preserved the cortical arteries, which I, of course, like to see and is important. So we're just going to be very methodical on. So that quadrant looks pretty good. There's a little hemosiderin there we'll take out. We came to the peel surface here. We were very prescriptive in protecting the deeper peel surface there. That looks hemosiderin on. So I feel that taking that out makes sense. You know, in the preoperative MRI scan, you can see the hemosiderin's feathered out quite extensively, so we have to be reasonable in our removal. Don't want to hurt her, of course. Looks pretty good. What do you think?
Sure, it's great.
Something right up here. Well, I think we should stop. We have a good removal. Now there's a touch of barely yellow brain here on. So maybe we'll shave that off just a little. I think it's important to make sure when you finish an operation that you've done your best for a patient. And I feel pretty comfortable with that here. Simple operation, but simple as eloquence. Search yourself. And now we'll do a standard closure. I tend to use Surgicel on. So we'll irrigate a little, put a little cotton ball in there can be helpful. So everything looks good. The brain is soft, no swelling, tells us there's no hematoma, no evidence of any epidurals, etc. So my red's going to tack these four corners of dura together. There'll be a gap in the middle, so we'll then take a little piece of pericranium or temporalis muscle down there as a tire patch. Honestly, this doesn't need to be watertight. We're not in a cistern, so I'm not really worried about a wound healing problem. Then we'll put the bone flap back on with some titanium MRI compatible metal plates. I like to recess the screws so the patient doesn't feel any bumps. Then we'll close the skin in 2 layers using staples. And as I said earlier, the patient will shower tomorrow, probably leave the hospital tomorrow, I suppose, depending on how she feels.
Yes, sir.
All right. Is there anything you do that I would narrate and you're going to show what I just described?
Yeah, one more, thanks.
Okay, 1, 2, 3, 4, 5, 6, 7, 8 passive markers. Yep. 1, 2, 3, 4 new markers. Yep. 1, 2, nose. Yep. 1 filter.